Good evening, everyone. I'm Ankit Aman, ninth semester, Director of Medical Education Society, GAIMS Mauritius. Whoever doesn't know about GAIMS, it stands for Global Association of Indian Medical Students. It's my honor to welcome all distinguished guests, experts, newly graduated doctors, and the future doctors who have made time and joined us today. Hypertension Day is recognized on 17th May yearly. With respect to this, we have came together to share our knowledge, insight, and learn about one of the most common illness affecting the individual. This event aims to facilitate meaningful discussions, idea exchange, and promote strategies for reducing the impact of hypertension. Now, I will over to Sana Shakil Ali, who will be the moderator for this event. Thank you.
Good evening, everyone. I welcome you all to the World Hypertension Day webinar. And thank you so much for joining this session. I'm Sana Shakil Ali, Director of Peace, Rights and Environment Society at James Mauritius, and I will be moderating this session. Before we get started, I would like to go over a few things so that you all can actively participate in today's session. In order to be considerate and respectful towards all the attendees and presenters, we all the attendees have been muted and shall remain so. There will be a designated time allotted for the questions, and you all can participate by raising your hand, and we can unmute you. If you experience any technical difficulties, please type in the chat box. And today we will delve into topics such as the risk factors, the lifestyle modifications, pharmacological interventions, patient education, and the vital role of technology in maintaining um, the treatment. I would like to take a moment to introduce our guest speakers for the day. So we have Dr. Sanjay Kumar Gupta, MBBS at PMC, MD at Rajendra Institute of Medical Sciences, and is currently working in the Health Department, Municipal Corporation of Delhi, and Dr. Gurpreet Singh Popli, MBBS and Diploma Anesthesia at CMC, and DNB Anesthesia from St. Stephen's, Delhi. Currently, the Director of Anesthesiology in CK Birla Hospital in New Delhi. Thank you so much for taking the time to be with us today. I encourage you all to actively engage in the discussions, seize the opportunity to network, and take back valuable insights. And at the end of the session, a link to the Google form will be provided, and you can fill them out and you'll receive your e-certificates. Without further ado, I would like to introduce Himanshu Dutta from Semester 2 at SSR Medical College.
Um, Hello everyone, welcome to the seminar. I'm Himanshu Dutta of second semester. I'm a committee member of Games Mauritius. So today here we are here today to discuss about hypertension as 17th May is observed as World Hypertension Day. But before we talk about hypertension, which is also known as high blood pressure, let us first understand what blood pressure is. Blood pressure is the force of circulating blood which is exerted on the walls of arteries. The value, which will be discussed later, are represented by two numbers. The first or the top number is known as the systolic pressure. This represents the value of the blood pressure when heart pumps blood to the rest of the body. The second number or the bottom number is the diastolic pressure, and it gives the value of the blood pressure when the heart is at rest. The unit of blood pressure is millimeter of mercury. So over here we can see that blood pressure has different classifications, and this is on the basis of their values. As seen in the table, a systolic pressure below 130 and a diastolic pressure below 80 is considered to be normal. A person's blood pressure is considered to be high when their blood pressure is when their systolic pressure is over 140 and their diastolic pressure is over 90. And if their systolic pressure is equal to or greater than 180, or if the diastolic pressure is greater than or equal to 110, then the person is said to be at a hypertensive crisis and an ambulance should be called for that person immediately. So now that we have discussed about the values, what is hypertension? Hypertension isn't just high blood pressure, because our blood pressure can be raised when we exercise or when we are stressed. Hypertension is a long term medical condition in which the blood pressure in the arteries is persistently elevated, which means that if our blood pressure is over 140 by 90 millimeter of mercury, then we have hypertension or we have a high blood pressure. This condition is common and can have severe consequences if left untreated. According to the World Health Organization, hypertension is a major cause of premature death worldwide. However, not everyone is at a risk of having hypertension. There are certain risk factors which come into play. These factors are either non modifiable, that is, these factors can't be controlled by the individual, or modifiable, that is, factors which people can work on to prevent hypertension or reduce its severity. So let's first go to non modifiable risk factors. As we can see here, we have four non modifiable risk factors, starting with age. People who are older, usually over 60 years, have a high chance of having hypertension. When it comes to sex, after adolescence, it has been observed that males have a higher chance of having hypertension than females. When it comes to genetic factors, then people who have hypertensive parents have a higher chance of having hypertension compared to those whose parents don't have hypertension. And when it comes to ethnicity, it has been observed that the black race has a higher chance of having hypertension. Now, moving on to modifiable risk factors. These risk factors can be controlled by a person, and they can lower their blood pressure by controlling these factors, starting with environmental stress and salt intake. When a person has too much of these, then they have a higher chance of having hypertension. But also, a person can have hypertension if they have a very unhealthy lifestyle, which includes people who are obese, people who have little to none physical activity, and people who regularly have an intake of saturated fats and alcohol have a high chance of having high blood pressure. That is all I have to share. Thank you.
Thank you, Himanshu, for the presentation. Moving on to the next speaker, Syed Ammar Ali from semester 2 at SSR Medical College.
Good evening, everybody. My name is Ammar. I am from semester 2 SSRMC, and I'll be talking about the complications of hypertension. We all know that high blood pressure can cause multiple complications. Formation of plaque causes narrowing of lumen, which in turn causes increase in blood pressure. We are aware of many complications already which arise from high blood pressure or hypertension. One is heart attack, stroke, heart failure. So, what exactly is stroke? Stroke is if the blood supply to brain reduces due to any blockage of arteries or narrowing of arteries, that may lead to stroke. We've got heart failure. So in hypertension, heart needs to work harder to pump blood, and this strain causes the walls to thicken. Like, for example, left ventricular hypertrophy. So in that case, there's a lot of pressure on heart, and that may lead to heart failure. You have kidney failure, in which there is high blood pressure, which causes vessels of kidney to become narrow or weak. That may cause renal failure. Talking about dementia, blocked arteries can limit flow to brain, and this may cause vascular dementia. Even in the case of retinopathy, like the damage to light sensitive tissues at the back of retina, this may cause bleeding in the eye and also blindness. And in coronary artery diseases, CAD, the blood supply to the heart is disrupted. And there's one more fact which I would like to add about retinopathy, that is that having hypertension along with diabetes increases the chances of retinopathy. Thank you. That was my.
Thank you, Amar, for sharing your thoughts on the topic. While we wait for our next presenter, I'd like to ask the audience if they know what the one food is that most of us like that has a positive effect on our blood pressure. You guys can make a guess and text in the chat box. Okay, so it's dark chocolate. Eating dark chocolate is a great way to incorporate more cacao into your diet, which can help lower your blood pressure. So that's an interesting fact. So our next speaker is Gia Bajaj from semester 3 at SSR Medical College.
Hi everyone, I'm Gia and I'll be presenting about how we diagnose a patient with hypertension. Uh, Hypertension is diagnosed by obtaining accurate representative blood pressure measurements of a patient and analyzing it in relation with standard thresholds. However, there are certain other objectives as well, identifying contributory factors, underlying causes which help us in providing accurate antihypertensive therapy, detecting any complications that are already present, such as allergies. Choice of drugs depend on whether other complications were correctly detected and diagnosed. Third would be assessing other risk factors such as job, age, weight, and more, as said by the earlier speaker, is beneficial in quantifying cardiovascular risk and providing more intensive care in high risk patients. Fourth would be identifying comorbidities also influence the choice of antihypertensive therapy. For example, spironolactone helps in lowering blood pressure and treating hypertension. However, it is a diuretic and increases the absolute risk of worsening kidney function. Thus, it is not prescribed to patients with both hypertension and kidney diseases. Now we'll talk about how to measure blood pressure by using a non-automated sphygmomanometer. Make sure you're using a machine that has been validated, well maintained, and properly calibrated. Make the next step would be to make sure to get consent from the person. After getting consent, move on to remove tight clothing from the arm and support it at the level of the heart. Make sure to use a cuff of appropriate size, especially in obese patients. The pressure in the cuff is first elevated well above arterial systolic pressure. Start lowering the pressure slowly at a speed of about 2 micromilligram mercury per second. Read the blood pressure by auscultating the first Korotkov sound, which are heard with every beat through a stethoscope. Use phase 5, disappearance of sounds to measure diastolic BP. You must take two measurements at each visit for accuracy and precision. Moving on, we'll talk about certain precautions and actions that help get better and accurate results during clinical blood pressure measurements. First is measurement should be made to precision of nearly 2 mmHg. Second, the subject must be sitting and have their arm rested on a table. Third, cuff should contain a bladder that encompasses at least two-thirds of the arm circumference in obese patients It helps to avoid spuriously high readings. The assessment is repeated after 5 minutes rest if it is higher than normal. Now we'll talk about ambulatory blood pressure measurements. These are continuous automated measurements over a period of 24 hours or more. This method provides systematically lower readings, approximately 12 systolic, 7 diastolic mmHg compared to every other clinical measurements. Thus, treatment thresholds and targets adjusted downwards. Continuing, we'll talk about this method's significance. First being it has better profile than a limited number of clinical readings. Since there are more amount of since there is more data, we get better profile. The second would be it correlates more closely with evidence of target organ damage than casual BB measurements because it gives you data with every second, and you can measure, like, you can check how the organ is failing according to the time. Third would be it guides management decisions since it gives you values all the time. The next would be home blood pressure monitoring. You must have seen the machines in your home if you have a hypertensive patient. These are commercially available semi-automated devices. However, this type of monitoring is dependent on the environment and timing. Environment meaning in your home if there is a fight going on and or something else, or the patient is under stress, the blood pressure would go high and you'll get a wrong, not wrong per se, but a different reading than usual. It also depends on timing. For example, in the morning, some people have higher blood pressure than at night. The significance of home monitoring would be that it is convenient for patients since it's at home. Patients with refractory hypertension can also use it. Patients with who have very unusually labile BP, labile meaning it changes very frequently, would have would use this method and would get better results. Patients with symptomatic hypertension would also get better results. In suspected white coat hypertension meaning that the person gets stressed out due to the doctor being present while the blood pressure is monitored. And in that case, since there is no doctor at home, there would be a better and more accurate reading. Now we'll move on to the thresholds. First of all, we'll talk about the normal blood pressures. For an optimal blood pressure, the systolic BP must be lower than 120, the diastolic must be lower than 80. For normal blood pressure, it must be in between 120 to 130, and diastolic should be lesser or around 85. For more, for higher normal threshold, it is 130 to 139 for systolic and 85 to 89 for diastolic. Now we'll move on to the thresholds for hypertension. First, there are three types. It is divided into three grades. The first being mild, second being moderate, and third being severe. For the mild one, systolic BP is 140 to 159, and diastolic being 90 to 99. For the moderate hypertension, the systolic BP is around 160 to 179, while the diastolic is 100 to 109. For high to normal hypertension, the systolic BP is greater than 180 and diastolic BP is greater than 110. Now we'll talk about isolated systolic hypertension. In this case, only the systolic BP is higher than normal. The diastolic BP is not higher, and it is divided into two grades. The first being the first grade has high systolic blood pressure of around 140 to 159, while the second grade has blood pressure greater than 160. Now we'll talk about further investigations. Um, these are investigations done after we diagnose the hypertension. Uh, these investigations are urine analysis, which are done for blood, protein, and glucose. Then blood urea, electrolytes, and creatinine. Hyperkalemic alkalosis may indicate primary hyperaldosteronism, but is usually due to diuretic therapy. Then we check for blood glucose, then serum total and HDL cholesterol, thyroid function tests, and 12-lead ECG, which is done to check whether the patient has left ventricle hypertrophy or coronary artery diseases. There are certain other specialized investigations also, which are done for patients who are very old. Certain examples would be chest X-ray, ambulatory BP, or echocardiogram. Uh, Now, thank you. This was my presentation, and I hope none of you have hypertension. If you do have, I hope you can maintain and thank you.
Thank you, Gia, for making us understand how to approach a hypertensive patient and providing us with valuable insights and practical guidance. Um, so, the next speaker is also from Anna Medical College. While we wait for him to share his screen, I would like to ask another question. So, this is a tough one, but yeah, here it goes. So, does anyone know how and when the first blood pressure recording was done? You can type it in the chat box and you can also take a wild guess, it's okay. Okay, so it was first done in 1711 by the Reverend Stephen Hales. So Hales inserted a glass tube into an artery of a horse and he observed the rise and fall of the blood in the tube. And then he concluded that this must be due to the fluctuating pressure in the arteries of the horse. So that is how it was first recorded. And I say that Anshu is ready. So moving on to Anshu Antony from semester 3 at Anna Medical College.
Well, thank you, Sana. Good evening, everyone. Today, I am going to speak about lifestyle modifications in hypertension. So, first things first, let's have a quick recap of what we have known till far. So, talking about hypertension, it's basically persistent high blood pressure, which in which your blood pressure could be more than 160 by 95 millimeters of mercury, which remains persistent even in rest. It requires medical intervention that includes dietary modifications, medications. And if your blood pressure is more than 180 by 120 millimeters of mercury, it requires emergency medical intervention. Let's talk about the prevalence of hypertension. So it is widely spread across roughly all the continents of the world, but it has higher prevalence in South Asia, Sub-Saharan Africa, Central America, and Europe. It affects 1 in 4 adults. So what are the things that lead to hypertension? Some of the reasons are you are overweight. The ideal human body mass index is 18.5 to 24.9. And if your BMI is over 25 to 30, you are at higher risk. And if your diet contains high salt, that is, if your sodium intake is more than 2,300 milligrams per day, it also increases the risk. Also, if you consume too much alcohol or coffee, it also increases the risk as alcohol increases the risk by approximately threefold. Smoking is one of the major causes and increases the risk by a whopping 26 to 39%. Also, if you lead a sedentary lifestyle in which that you do not exercise or you are taking too much stress, can also increase the chances of getting hypertension. Studies have shown that vulnerable people who exercise are at 19% lesser risk. Last but not least, if there's some underlying diseases like kidney diseases, diabetes, hormonal imbalance, or if you have a genetic problem, it also increases the risk. So when you have to see a doctor, although high blood pressure does not cause symptoms, anyone with sudden or severe headache, which may be followed with nose bleeding, and if you have chest pain, you should seek doctor's consultation immediately. And if your blood pressure is more than 180 by 120 millimeters of mercury, seek medical help as soon as possible, as this could be hypertensive crisis. So diagnosis, as which has been already spoken by the previous speaker, but there should be blood pressure screening for the vulnerable age group, that is 35 years and above. And ambulatory blood pressure monitoring is the most effective way to diagnose it. Talking about treatment and management, you can broadly classify into three groups, that is diet planning, exercise, and medication. Diet planning includes DASH diet, which I will be talking about shortly. So DASH diet, what is it? DASH stands for Dietary Approaches to Stop Hypertension. In simple terms, it is basically a diet rich in fruits, veggies, and whole grains, and is low in saturated and trans fat. The main principle of DASH diet is to decrease sodium intake, increase potassium intake, and decrease alcohol consumption. Let's talk about sodium intake. So the daily sodium intake should be less than 1500 milligrams. And as you must have, as you all know, like many are bachelors and students also prefer to take prepared meals. But mind you, according to the guidelines of Center for Disease Control and Prevention, prepared meals should contain less than 600 milligrams of sodium to be deemed as healthy. Avoid processed meat and reduce condiments use, that includes your sauce, seasoning, etc. Talking about potassium intake, daily potassium intake should be 3.5 to 5 grams, which can be increased with which can be fortified with increased fruit and veggies consumption. For example, consume oatmeal and carrot juice for vegetarians as it is the richest source for potassium. And if you're a non-vegetarian, seafood and low-fat milk could be a good source of potassium. Talking about alcohol intake, there should be strict reduction in consumption of alcohol, and cessation is preferable. In in terms of limits, for males, less than 2 drinks daily is the higher limit, and for females, strictly 1 drink maximum. Counseling of alcohol use disorder should be opted if necessary. One important point to note is smoking cessation is a must to avoid ASCVD risk, which is basically atherosclerotic cardiovascular disease. Moving on to exercise. So what you can do. So the most effective exercise is aerobic exercises, which includes your walking, cycling, or hiking. And it is advised to do at least for 90 to 150 minutes. Talking about dynamic resistance, which is in simple terms your gym, it is ideal to it's ideal for doing weight training and aim to do 6 exercises with 3 sets each for roughly 90 to 120 minutes. One really good thing to note is yoga. Yes, doing yoga 3 times a week has significant reduction in blood pressure. And this is the most effective measure, that is weight loss. So weight loss is aimed at attaining ideal body weight and body mass index, as I already talked earlier. So the ideal body mass index is 18.5 to 24.9. And one interesting thing to notice here is it approximately reduces 1 millimeter of mercury per kg reduction in body weight. So I would like to conclude my presentation. Although there is no cure for hypertension, lifestyle modifications have paramount importance to lead a healthy life. Thank you.
Thank you, Anshu, for discussing this crucial topic of lifestyle modification for hypertension. So, our next speakers are Suzain Ali from semester 9 at SSR Medical College and Dr. Guneet Popli, graduate from SSR Medical College.
Good evening to one and all present here. I'm Suzain Ali, student of SSR Medical College. So today, me and Guneet Popli will be going through pharmacotherapy of hypertension. We'll be helping you understand what drug to use and how those drugs work in your body to reduce your blood pressure. So the most commonly prescribed drugs that are used today are ACE inhibitors, ARBs, beta blockers, calcium channel blockers, diuretics. An easy way to remember them is A, B, C, and D. So firstly, we'll be going through ACE inhibitors and ARBs. So the basic mechanism of action that goes with ACE inhibitors and ARBs is that they act on your renin-angiotensin system. So the ACE inhibitors that are available or that will be prescribed to you by your doctor will be enalapril, captopril, lisinopril. So ACE inhibitors are capable of reducing your systolic, that is the blood pressure that has 120, 130, 140 range, and diastolic 90, 80, 100 range by dilating both arteries and veins. These are the first line drugs when you get diagnosed with hypertension if you're aged less than 55 years. Angiotensin receptor blockers. So angiotensin receptor blockers are candesartan, valsartan, and losartan. Any drug basically that ends with sartan is an angiotensin receptor blockers. So ACE inhibitors and ARBs, they share a similar mechanism of action. So I'll be letting you know in brief what happens and how they work. So when you have hypertension, that is elevated blood pressure, there will be reduced blood flow to your kidneys. So whenever there's reduced blood flow to your kidneys, they get stimulated and they release renin. So renin is a molecule that causes the conversion of angiotensinogen to angiotensin 1. Now, the lungs get stimulated and they release angiotensin converting enzyme, which is responsible for the conversion of angiotensin 1 to angiotensin 2. I know these are pretty difficult molecules to remember, but all you have to remember is that this final molecule, angiotensin 2, is responsible for releasing antidiuretic hormone from your brain. So basically, what will happen now is that it will cause the stimulation of smooth muscles in your arteries and your veins and cause them to contract further, thereby increasing your blood pressure. On the other hand, it will also act upon your kidneys and cause reabsorption of sodium and water. So whenever we say that there's elevated blood pressure, we mean that your heart rate, that is your heart, is contracting faster. And there's an increased volume of blood in your body. So now what will happen is that when you get prescribed an ACE inhibitor or an ARB, that is basically captopril or losartan, it will prevent the conversion of angiotensin 2 from angiotensin 1, thereby stopping the process at angiotensin 1, as you can see in the diagram. So now what will happen, all the effects that we studied, that there will be smooth muscle contraction causing your arteries to constrict, and sodium and water retention in your body, it will all get reversed. So now your arteries and your veins, like I said, they will dilate and reduce the heart rate. And the sodium and water retention that was happening will get reduced. So the circulating volume in your body will get reduced, thereby reducing the blood pressure. So some of the things that you should remember when you're prescribing ACE inhibitors or when you are prescribed ACE inhibitors or ARBs. If your patient complains to you about dry cough or you start developing dry cough, please visit your physician because it is a very important adverse effect that comes with ACE inhibitors. This can be prevented by giving ARBs because this is quite specific to ACE inhibitors. By ACE inhibitors, I mean captopril, enalapril, or lisinopril. Avoid using ACE inhibitors or ARBs in cases of pregnancy as they cause fetal malformations. And another life-threatening side effect that you have to remember whenever you're using or prescribing ACE inhibitors, that is captopril, enalapril, or lisinopril, is angioedema. Angioedema is edema and swelling of the lips, because of which there will be obstruction to airway entry, thereby compromising your airflow. So this is again a specific effect that happens with ACE inhibitors. So it's advisable to use ARB, that is any drug that ends with sartan, that could be losartan, candesartan, or valsartan. Now coming to another class of drug, that is beta blockers. So in your body, blood pressure is also maintained by the autonomic nervous system. So the autonomic nervous system has receptors, alpha receptors and beta receptor. Today we'll only be concerned with beta receptors. So beta receptors, there are two types of beta receptors. We have beta receptor 1 and beta receptor 2. Beta receptor 1 is present in a single heart. We have one heart, so it's easy to remember beta receptor 1. And beta receptor 2 is present in your lungs. We have two lungs, so beta receptor 2. So beta blockers are classified very broadly into cardioselective and non-cardioselective. Cardioselective beta blockers are the one that will only act on beta 1 receptor. That is, they'll only act on your heart. And non-cardioselective beta blockers are the ones that will act both on your beta 1 and beta 2. Some of the beta blockers that are available are propranolol, carvedilol, atenolol, and metoprolol. So any drug that your doctor is prescribing you that ends with a lol, you know that it's a beta blocker. So now what happens when you take a beta blocker? Normally, whenever the beta receptor is stimulated in sympathetic drive, that is when you're frightened, when you're in an emergency state, your heart rate increases. This is because the beta receptor gets stimulated. So now, when you give a beta blocker, the drug will go and inhibit the beta receptor that is present in the heart and also in the blood vessels, thereby reducing the heart rate. And as I said, blood pressure is governed by heart rate, thereby reducing your heart rate. But beta blockers are not primarily used as first line agents. They're preferred in younger patients. They'll usually be given when you have a lot of anxiety, you have migraine, or if you're having deranged thyroid levels or hyperthyroidism. One important indication for medicos to remember is that beta blockers should be given in hypertensive patients who have had an attack of myocardial infarction, basically heart attack. This is done in order to reduce the risk of arrhythmias. To make it simple for the non-medicos, arrhythmia is irregular contractility of your heart, like it won't be functioning in a proper way. So to regulate that, we give beta blockers. Some things that you have to remember before prescribing beta blockers, or you have to make your patient aware of the side effects, is that they can have hypotension, they might feel dizzy, they may feel fatigued, you may feel tired, they might complain to you with difficulties in sleeping. And two important things that you have to remember is that in males, it might cause sexual dysfunction. So we should try using other drugs that do not cause sexual dysfunction. But this is a very long-term effect. And another thing is that when I told you that there are cardioselective and non-cardioselective beta blockers, it was for the purpose to remember that if you are an asthmatic or if you are prescribing a drug to an asthmatic, you should remember to choose a cardioselective beta blocker. That would be metoprolol or atenolol, because non-cardioselective beta blocker will go and act on the lungs, thereby causing your airway to become narrow or bronchoconstriction, which could impede your airflow, thereby causing an acute asthmatic episode. Now I'll be giving over to Dr. Guneet, who will be continuing on the drugs available. Thank you.
Hi everyone. Suzain just talked about ACE inhibitors, ARBs, as well as beta blockers. Remember she started with A, B, C, D. The C here is calcium channel blockers, and these are the first line drugs that we would use in a patient who's more elderly. While ACE inhibitors might be the first choice for a person below 55 years of age, for a patient above 55 years of age, we would prefer calcium channel blockers. So calcium is something that can go in your blood vessels and cause constriction of these blood vessels. It causes contraction of all the smooth muscles present in the vessel wall and hence constricts your blood vessels. When you block that action, your blood vessels dilate and your blood pressure comes down. So calcium channel blockers are mainly acting by decreasing your peripheral resistance. They are of two types. We have all the drugs that end with dipine, which you might have commonly heard, are dihydropyridines like amlodipine, nifedipine, and all the drugs, just two of them are main drugs for non-dihydropyridines, which are verapamil and diltiazem. They also bring the blood pressure down, but the preferred agent are the dihydropyridines, that is amlodipine and nifedipine. There are a few advantages that we get with calcium channel blockers, which other classes of drugs do not provide. For example, there are no metabolic side effects. If we prescribe something like diuretics, which I'll be talking about soon, patient can end up in hypokalemia. They might have hypocalcemia on long-term use. That's decreased levels of potassium and calcium. However, calcium channel blockers do not cause such effects. They do not lead to sexual dysfunction either. Suzain just mentioned that beta blockers can cause erectile dysfunction with long-term use, and so do thiazides do that. But calcium channel blockers have this particular advantage that they are not going to cause any sexual dysfunction. If there is hypertension associated with peripheral artery disease, and even if it's a young patient, we would go for calcium channel blockers. That's because calcium channel blockers cause peripheral vasodilation by the mechanism I just explained. The next class of drugs, which is the D in the ABCD classification, is diuretics. So, in simple terms, diuretics act on your kidneys to cause more and more sodium and water excretion. The more water you lose, the more sodium you lose, your blood pressure keeps coming down because your blood volume is getting decreased. So the three main diuretics we know about as antihypertensives are thiazide diuretics, loop diuretics, and potassium sparing diuretics. So thiazide diuretics is something you might have all heard. It's given, hydrochlorothiazide tablets are usually combined with other classes of drugs like calcium channel blockers for control of BP. These thiazide diuretics act in the nephron on the kidney. So for all those who are new here, are non-medicos, nephrons are the basic functional unit in a kidney. All the filtration, all the secretion, all activity takes place by these nephrons, which have a proximal tubule and a distal tubule. The thiazides go and act on this distal tubule to make more and more sodium and water excrete. On the other hand, we have loop diuretics, which mainly act on this loop of Henle. They will act on the ascending loop of Henle in the nephron, so that more sodium and water can be excreted. And the potassium sparing diuretics act on the last part of the nephron, which is the collecting duct. So thiazide diuretics, hydrochlorothiazide, like I mentioned, is the most common that we use. The short-term mechanism is by sodium and water loss. They're going to bring down the blood pressure, but with long-term usage, they are going to change the compliance of this blood vessel as well, and that also will lead to reduction in blood pressure. There are a few drawbacks. Because the sodium is being lost constantly, this patient might come back with complaints of fatigue and muscle weakness. It can also cause decrease in the potassium levels, causing hypokalemia in this patient, and they cause an increase in uric acid level. So any patient who has gout, thiazide diuretics is definitely not the drug of choice for them. Then talking about loop diuretics, the commonly used term we use in the market is called as Lasix, and the medical name for that is furosemide. These drugs are mainly used to lower the blood pressure in acute emergency situations. We do not prescribe them as antihypertensive medicines for daily usage because the patient might develop tolerance. They have a good advantage of causing a rapid reduction in blood pressure. They act for a short duration and hence are very well used for any hypertensive emergency. Also, in a patient having hypertension with a low GFR, loop diuretics can be used. This is because loop diuretics, if you keep increasing the dose, they can surpass the renal dysfunction that has occurred in the body. Coming to potassium sparing diuretics, the most common examples are spironolactone and eplerenone. These are used in patients with resistant hypertension. Resistant hypertension is mostly because of excess of aldosterone. Like Suzanne explained the RAS pathway, where we talked about angiotensin 2 being the final molecule going and acting in the kidneys to release aldosterone, and aldosterone causes sodium and water retention. Now, I'm going to block that action by giving potassium sparing diuretics by inhibiting this aldosterone. Once this aldosterone is inhibited, we have more and more sodium and water being excreted, and hence they will bring down the blood pressure. So, any case where there's resistant hypertension, also resistant hypertension means this patient is already on more than 3 classes of antihypertensive drugs, and still the blood pressure is not coming down. In such cases, we will use potassium sparing diuretics. The pharmacotherapy and what are the drugs of choice we use currently will be better explained by our guest now. Thank you.
Thank you, Suzanne and Dr. Guneet. And I think it is very important that we know about the positive effects and the side effects of these widely used drugs, seeing at how prevalent hypertension is. And if you are concerned about your blood pressure because of your family history or your current lifestyle, it is essential that you consult with your healthcare professional for personalized advice and guidance. They can help you understand your blood pressure readings and develop a proper plan for managing your hypertension and help you to monitor your overall health. Our next speaker is Dr. Sanjay Kumar Gupta.
Yeah, I am audible. Am I audible? Hello, good evening, everyone. On this occasion of World Hypertension Day, I am going to talk about routine management in different cases of hypertension, including hypertensive crisis. Now, topics to be covered are essential hypertension, treatment of hypertension in special situations, secondary hypertension, and hypertensive crisis. Now, almost 95% of the cases with hypertension are idiopathic. No cause is identified. Coming to the goals of therapy, I'm going to start again. Hello everyone. On this occasion of World Hypertension Day, I am going to talk about routine management in different cases of hypertension, including hypertensive crisis. The topics to be covered are essential hypertension, transient treatment of hypertension in special situations, secondary hypertension, and hypertensive crisis. Now, essential hypertension constitute about 95% of all cases in which no cause of hypertension can be identified. Now, the goal of the therapy is to prevent, reverse, or delay the progression of complications and thus reduce the overall risk of an individual without affecting the quality of life. Antihypertensive therapy should achieve and maintain systolic blood pressure below 90 and even lower if tolerated, while controlling other modifiable risk factors. Now, gradual reduction of blood pressure to the optimal level over a period of 2 to 3 months is required, of course, except in stage 3 hypertension. Now, decisions should not be taken alone by the level of blood pressure, but also the risk factors of cardiovascular diseases as enumerated in the screen may be taken into account. Plus, evidence of target organ damage should also be assessed. These are left ventricular hypertrophy, proteinuria, focal narrowing of retinal arteries, and atherosclerotic plaque in the carotids, along with associated clinical conditions such as cerebrovascular disease, heart disease, renal, vascular, and retinopathies. We have to take all these 3 factors into account before stratifying the risk in hypertension. Just take, for example, in this table, stage 1 hypertension is classified at the level, numerical level of systolic blood pressure between 140 and 59 and diastolic pressure between 90 to 99. So when no risk factor is attached with it, then this is categorized in low risk group. But as soon as this stage 1 hypertension is associated with one or more risk factors, then it becomes medium risk. Likewise, if 3 or more risk factors or target organ dysfunction or diabetes, then it becomes a high risk. And when this stage 1 is associated with other clinical conditions, as discussed earlier, it becomes a very high risk. Now, how to proceed? For low-risk patients, institute lifestyle modifications and observe blood pressure for a period of 3 months before deciding whether to initiate the drug therapy or not. In medium-risk patients, institute lifestyle modification and observe blood pressure on a monthly basis for a period of 3 to 6 months. If the blood pressure remains consistently above 140/90, then initiate the drug therapy. For high and very high risk patient, the drug treatment should start immediately along with any comorbid condition. Now, coming to the management strategies. Now, achieve gradual reduction of blood pressure using low doses to initiate therapy. For stage 1 and 2 hypertension, 6 classes of drugs are recommended all of which are equally effective. These include diuretics, beta blockers, ACE inhibitors, calcium antagonists, alpha blockers, and ARBs. Now, choice of an antihypertensive agent is influenced by age, risk factors, target organ damage, coexisting disease, and other factors, as stated, as you are as I am sharing with the screen. Now, combining low doses of two drugs having synergistic effect is likely to produce lesser side effects than higher dose of a single drug. Use of fixed dose formulations are to be discouraged for initiating the therapy. It can be used later on when the effective blood pressure is controlled. And third, use of long-acting drugs that provide 24 hours efficacy with once daily administration ensures smooth and sustained control of blood pressure. It also improves patient's compliance and provides greater protection against cardiovascular events and target organ damage. Now, generally the treatment of antihypertensive is lifelong. But once the blood pressure is controlled, there should be an effort to decrease the doses and the number of drugs. And that is known as step-down therapy. Second, due to seasonal variation of temperatures, the doses may be adjusted. For example, in extreme cold cases, there is peripheral vasoconstriction leading to elevation of blood pressure. In this case, the dose of the drug should be increased. Likewise, in summer, there is vasodilatation and low level of drug can be used to control the blood pressure. Now, if addition of a second agent controls the blood pressure effectively, then there should be an effort to remove the first agent. This is the general guideline for selecting the drugs in treating hypertension. I think I will omit this slide because I think this has been already discussed. Now, coming to treatment of hypertension in special situations, I am taking especially 6 categories: diabetes, ischemic heart disease, cerebrovascular disease, pregnancy, obesity, and elderly hypertensives. Now, what are the special considerations in the treatment of diabetic hypertensive patients? As you know, hypertension is twice as common in diabetics than those in normotensive patients. Hypertensive patients with diabetes are at particularly higher risk for cardiovascular events. So, more aggressive treatment in these patients is needed to prevent progressive nephropathy, myocardial infarction, and stroke. Now, the treatment recommendation suggests blood pressure target of less than 130 by 80. ACE inhibitor or ARBs should be a part of initial treatment because it helps in decreasing diabetic nephropathy. Here is an outline for treating hypertension in patients with diabetes. As I said earlier, the treatment goal should be less than 130 by 80 to prevent target organ damage. Now, initiate pharmacological therapy in alphabetical order: A, B, C, D. A for ACE inhibitors or ARBs, B for beta blockers, C for calcium antagonists, and D for diuretics. Now start with a single dose and control the blood pressure by gradually increasing the dose. If it is not enough, then add a second agent, and that should preferably a low dose diuretic. If those two agents is not enough to control the blood pressure, then add the third one of which should be a diuretic. Now, treating hypertension in ischemic heart disease. ACE inhibitors and long-acting calcium antagonists are the drugs of first choice. The antihypertensive agent of first choice with stable angina is a beta blocker, or if contraindicated, as in asthmatics, a long-acting calcium antagonist can be used. Now, in hospitalized patient with an acute coronary syndrome, hypertension should be treated with a beta blocker, or if contraindicated, verapamil or diltiazem in absence of severe left ventricular dysfunction. Now, hypertension in cerebrovascular disease. Specific blood pressure targets have not yet been identified with acute cerebrovascular events. But we have to keep in mind that steep decline in blood pressure after ischemic stroke may lead to increased infarct size. In acute ischemic stroke, moderate blood pressure elevation can usually be managed conservatively, but blood pressure must be more tightly controlled if thrombolytic therapy is used. In intracerebral and subarachnoid hemorrhage, hypertension should be treated as it is of moderate or marked severity. For secondary prevention, people with a transient ischemic attack or cerebral infarction, they benefit from reduction of blood pressure. Now, the drug management in case of cerebrovascular events. In all the three cases, that is cerebral infarction, intracerebral hemorrhage, and subarachnoid hemorrhage, IV sodium nitroprusside should be used if the diastolic blood pressure is more than 140. If the systolic blood pressure is in between 180 to 220 and diastolic blood pressure 105 to 120, in all the three cases, intravenous labetalol can be used. No acute treatment is required if the systolic blood pressure is less than 180 and the diastolic blood pressure less than 105 in all the three cases. Now, coming to the treatment of hypertension in pregnancy. Most women with chronic hypertension in pregnancy have stage 1 or 2 hypertension and are candidates for non-drug therapy, as there is no evidence that pharmacological treatment leads to improved neonatal outcomes in stage 1 and stage 2 hypertension. Now, 25% of these women will progress to preeclampsia. Now, we should keep in mind that key to management of hypertension in pregnancy is to differentiate preeclampsia, which is a pregnancy-specific syndrome of exaggerated vasoconstriction and reduced organ perfusion, from the pre-existing chronic hypertension. Now, the classification of hypertension in pregnancy. The first is, of course, the chronic hypertension. Now, systolic blood pressure equal or more than 140 and diastolic blood pressure equal or more than 90 before pregnancy or before 20-week gestation and persist more than 12 weeks postpartum. The second type is preeclampsia, in which the criteria is systolic blood pressure equal or more than 140 and diastolic blood pressure equal or more than 90, with proteinuria more than 300 milligram per 24 hours after 20 weeks of pregnancy. It can progress to eclampsia. The third type is chronic hypertension with superimposed preeclampsia. There are two criteria for this. First, new onset proteinuria after 20 weeks of pregnancy in a woman with hypertension. And the second is in a woman with hypertension and proteinuria before 20 weeks of pregnancy, but there is sudden 2 to 3-fold increase in proteinuria subsequently. The third type is this gestational hypertension, which is hypertension without proteinuria occurring after 20 weeks of gestation, and it may involve to preeclampsia. And the third type is, and the fifth is the transient hypertension, which is in fact a retrospective diagnosis. Blood pressure becomes normal by 12-week postpartum, but it may recur. This hypertension may recur in subsequent pregnancies, and it is an important predictor for future essential hypertension development in such patients. Now, selecting drugs in pregnancy for chronic hypertension, of course, methyl-dopa is preferred based on long-term follow-up for about, say, 10 years, more than 10 years. Beta blockers are generally safe. However, IUGR has been reported in some cases with atenolol. Nowadays, labetalol is increasingly preferred to methyl-dopa due to reduced side effects. Now, in acute severe hypertension in preeclampsia, intravenous hydralazine is the drug of choice. Intravenous labetalol can be used as a second line. The use of oral nifedipine is controversial, and it can cause a steep fall in blood pressure if used with magnesium sulfate. Intravenous sodium nitroprusside is used when the above treatment fails, and one important side effect is that the fetal cyanide poisoning may occur if it is used for more than 4 hours. Now, coming to obese hypertensives. Increased fatness, that is body mass index, and central fat distribution, that is waist circumference, are associated with high blood pressure. Lifestyle behavioral changes of diet and activity can improve and help to control the elevated blood pressure in such cases. These patients usually take weight loss medicines such as sibutramine, which itself causes an increase in blood pressure. And other frequently used drug by them is orlistat, which can cause steatorrhea. Now, in principle, higher doses of antihypertensive medications and drug combinations may be needed in obese hypertensive patients to control blood pressure. Now, the treatment of elderly hypertensive patients. Now, 75% of the individuals over 60 years or older develop high blood pressure. This is a process of aging in which the arteries loses its elasticity and becomes stiffer, thereby increasing the blood pressure. Now, the important thing is here that the cardiovascular risk is related to increased systolic blood pressure and pulse pressure and to decreased diastolic blood pressure. But systolic blood pressure reduction is the major target for improving outcomes in the elderly patients. Besides, other lifestyle changes, especially weight loss and sodium restriction, should be advised, and it helps in decreasing the need for antihypertensive medication. Now, the recommended systolic blood pressure goal is less than 140. Diuretics, calcium antagonists, and ACE inhibitors are the first line drugs in older patients with systolic hypertension. Now, coming to secondary hypertension. In all the hypertension cases, 5% of the cases is due to a consequence of a specific disease or an abnormality leading to sodium retention and or peripheral vasoconstriction. Treatment of these cases are directed towards addressing that specific disease or abnormality. And in most of the cases, the specific disease abnormality is treated. If that is treated, hypertension comes under control. Now here are some of the causes of secondary hypertension: renal diseases, renal artery stenosis, glomerulopathies, polycystic disease, then the various endocrine diseases like pheochromocytoma, Cushing's disease, hyperaldosteronism, hyperparathyroidism, thyrotoxicosis, etc. Then the drugs, oral contraceptives containing estrogen, anabolic steroids, and others. Of course, pregnancy and others. In others, there is coarctation of aorta and alcohol use. Now, coming to hypertensive crisis, in which we first will discuss hypertensive urgencies. These are severe elevations in blood pressure without evidence of acute or rapidly progressive target organ dysfunction. So there is no target organ damage. Elevated blood pressure alone, in absence of progressive target organ damage, can usually be managed by oral drugs. And this can be administered in emergency room with regular follow-up. When follow-up is not possible, they can be treated in hospital. Now, some of the causes of hypertensive urgencies: glomerulopathies, excessive body burns, scleroderma crisis, acute systemic vasculitis, severe epistaxis, then autonomic hyperreflexia syndrome, and drug-induced hypertension, and rebound hypertension after sudden withdrawal of antihypertensive agents. Now, for many patients with hypertensive urgencies, initiation of therapy with two agents is appropriate to lower blood pressure over 24 to 48 hours. If required, a third agent may be added. The preferred oral drugs are labetalol, prazosin, clonidine, and nifedipine. Now, dealing with hypertensive emergencies. They occur when severe elevations of blood pressure are complicated by evidences of acute or rapidly progressive target organ dysfunction. So in this, target organ damage is present. Such emergencies require immediate blood pressure reduction within minutes to hours to limit or prevent target organ damage and reduce risk. These patients, of course, have to be treated in intensive care unit with constant blood pressure monitoring. Now, various causes of hypertensive emergencies are hypertensive encephalopathy, malignant hypertension, rapidly progressive renal failure, cerebrovascular events, head trauma, cardiac, such as acute aortic dissection, and acute renal left ventricular failure with pulmonary edema, unstable angina. And in pregnancy, eclampsia and other catecholamine excess states. Now, this is important. Drugs in the treatment of hypertensive emergencies. Intravenous sodium nitroprusside is preferred, and it comes under the parenteral vasodilators, the first group. Intravenous sodium nitroprusside has an onset of action which is immediate. However, there are some side effects such as thiocyanate intoxication, methemoglobinemia, cyanide poisoning. Here, one very important precaution is that the bags, bottles, delivery sets must be light resistant because sodium nitroprusside is light sensitive. The second drug is glycerol nitrate. The onset of action is 2 to 5 minutes. It can cause headache, tachycardia, and flushing. Verapamil, the onset of action is 1 to 5 minutes. Avoided in heart block and beta block with the use of a beta blocker. Intravenous diazoxide, the onset of action is 2 to 5 minutes. It can cause hypertension and tachycardia. Now, the second group drug are the parenteral adrenergic inhibitors. The first is the intravenous labetalol, onset of action 5 to 10 minutes, avoided in bronchoconstriction and heart blocks. Then second is intravenous esmolol, onset of action 1 to 5 minutes, and avoided in first degree heart blocks, congestive cardiac failure, and asthma. And the last is injection phentolamine, onset of action within 1 to 2 minutes. It can cause tachycardia and orthostatic hypotension. Thus now I conclude my talk. Hope that I have been able to convey to you all the concise information about management of hypertension from a physician perspective in both outdoor and indoor settings. Thank you.
Thank you so much, Dr. Gupta, for sharing your expertise on how to manage a hypertensive patient. Your insightful presentation highlighted the important aspects such as the different management strategies and the different modes of treatment in the special situations. Now, if anyone has any questions, they can unmute themselves, and I'm sure Sir would be pleased to answer them.
Hello, sir. Can I ask you a quick question, please?
Yes.
Yeah. First of all, I would like to thank you for taking out your valuable time and effort for joining us. And could you please elaborate on why we should decrease the blood pressure slowly and not very abruptly in cases of acute stroke?
Uh, just a minute. Okay. Now, just to answer your question, you are hearing me?
Yes, sir. You're audible.
Yes, I'm audible. Okay. Now, in cerebrovascular events, there is increased intracranial pressure, and this leads to decreased cerebral perfusion. So, a higher blood pressure is required to maintain that cerebral perfusion. So, if you suddenly decrease the blood pressure in CVA or cerebral vascular accidents, that cerebral vascular perfusion will decrease and it will increase the infarct size, leading to more complications. Do you understand, or I have to elaborate more?
Yes, sir. Got it. Thank you.
Okay, thank you. Anything more?
Thank you, sir. Now we'll proceed to the next speaker. Our next speaker is Dr. Gurpreet Singh Popli.
Hi, good evening, everyone. First of all, I would like to convey my appreciation to the organizers for organizing such an excellent webinar on hypertension. And also, I would like to appreciate all the speakers who have given such a great detail about hypertension. And it is really an concise and extensive revision of hypertension and how is to be dealt with and managed in day-to-day life. We all know that hypertension is one of the lifestyle chronic lifestyle disease which has a very high prevalence. 1 in 4 people will have hypertension globally, also in India. So, thanks to Dr. Sanjay for such a great and extensive talk about management of hypertension and also stratifying our patients. I'm an anesthetist, and anesthetist, whenever we get a patient who has an hypertension, the easiest thing for us is to refer to a physician for risk stratification and further management of these patients so that we can accept them for surgeries. So Dr. Sanjay has done that. He has stratified our patients in a very good way. And now I think we are ready to go ahead and anesthetize our patients. I'll be talking on hypertension management for anesthesia and surgery. Before that, I would just like to talk a little bit about the epidemiology of hypertension, what a burden it is in India. It ranks as a second leading risk factor for men, whereas it's a leading risk factor for women. And it accounts for about 90 million disability adjusted life years, that is DALYs among women, and about 125 million DALYs among men. Coming to definition of DALYs, just to explain it to you, DALYs actually means it's DALYs for any disease or health condition are some of the years of life lost due to premature mortality and years lived with disability due to prevalent cases of diseases or health conditions in the population. Out of this, ischemic heart disease adds maximum to the DALYs, where other followed by hemorrhagic stroke and ischemic stroke. The overall prevalence we have been talking ever since we started this webinar is 1 in 4 people will have hypertension. In India also, it is about 30%, out of which 34% population is in India, is in urban area, whereas just 28% in rural area. Out of the 34% people in urban area who are hypertensive, only 38% are being treated for hypertension. In rural area, the treatment being offered is only to 25% patients who are known hypertensives. Why do we need to treat and optimize hypertension before we take them up for surgery? We have gone through the webinar, and we know that hypertension leads to damage of other organs. End organ damage is the main concern we are worried about, like nephropathy, CVA, ischemic heart disease, cardiac failure, and all, and many more. If we proceed without optimization, then there will be a lot of hemodynamic instability, which can lead to heart failure, fatal arrhythmias, myocardial infarction, cerebral vascular adverse events, and leading to mortality. So, we need to optimize our patients before we take them up for any surgical procedure. What are the main risk contributors because of hypertension? The main ones are target organ damage, which hypertension normally does. Isolated systolic hypertension with increased pulse pressure and diastolic dysfunction predominates in the elderly and constitutes a particular perioperative risk profile. Diastolic dysfunction that has led to LVH is another major risk factor which can lead to morbidity and mortality during the surgical procedure or anesthetic intervention. Whenever we talk about different risk indices, it is surprising that none of the risk indices will mention hypertension as one of the risk index, be it Goldman multifactorial cardiac risk index or a revised cardiac risk index or a surgical risk calculator. But most of the factors mentioned in these risk indices are secondary to long-standing hypertension. So indirectly, hypertension does lead to a major risk during anesthesia and surgery. What is our goal? Our goal is effective intraoperative management, which should be basically within 20% of plus or minus of the preoperative blood pressure of the patient. When we do a preoperative evaluation of any hypertensive patient, there are a few questions we need to answer. What could be the cutoff blood pressure value to postpone an elective surgery? If postponed, what should be the target of BP? If postponed, what should be the time duration of blood pressure optimization? When does autoregulation curve shift towards normal area? What is the target intraoperative blood pressure? Talking about cutoff value, any blood pressure, systolic blood pressure more than 180 and a diastolic more than 120, that is, as we have seen in the classification, it is stage 3 hypertension. We will postpone this patient and optimize this patient before we take up for surgery. Otherwise, we will end up into a perioperative dysarrhythmia, myocardial ischemia, myocardial infarction or stroke, and other complications. The target BP for patient depends on patient's age. If age is less than 60 years, the target BP should be less than 140 by 90. In a diabetic, the target BP should be less than 140, 90 millimeters of mercury. A patient with kidney disease also target BP should be less than 140 by 90, whereas a patient who is more than 60 years, we will accept a blood pressure of 150 by 90. Duration of blood pressure reduction. This was a question asked during last presentation. Why would we not decrease the blood pressures suddenly? For elective surgeries, effective blood pressure control can be achieved in several days or weeks. Why we do not reduce it suddenly? As Dr. Sanjay rightly said, it is because we have to maintain the blood sugar, you have to regulate the blood pressure in auto regulation curve. So we have to bring this auto regulation curve towards normal, which can take 4 weeks to up to 4 weeks. And the strategies we would like to use to decrease the blood pressure is gradual until and unless it's an hypertensive emergency, because reducing it very quickly and below the autoregulatory zone can result to decreased perfusion to the brain and eventually ischemia and infarction. There is no role of cosmetic correction of asymptomatic uncontrolled hypertension. Newly diagnosed stage 1 and stage 2 hypertension patients without any end organ hit can be accepted for surgery, provided we manage the blood pressure adequately during and after the surgery. What is target intraoperative blood pressure? The target intraoperative blood pressure should be systolic or mean arterial pressure plus minus 20%. That is a sweet spot. The sweet spot is plus minus 20% of the normal blood pressure, which is preoperative for that individual. Since most of these hypertensive patients will be on one or other or combination of antihypertensive drugs. So there are few interactions an anesthetist is supposed to know about with anesthetic agents these drugs can have. The interaction can is divided into two categories. One is interference with hemostatic mechanism necessary to maintain perioperative cardiovascular stability, and the other one is actual direct interaction or potential interactions. So there will be responses to cardiovascular system depressant drugs. Blood and fluid losses can lead to interaction. During positioning also there might be changes in blood pressure or fluctuation in blood pressure, especially in patients who are on these antihypertensive drugs. Pulse pressure variation requires an intact sympathetic nervous system which is obtended under anesthesia. So there might be a major pulse pressure variation in these patients. The common interactions we see with anesthetic agents is diuretics lead to hypokalemia and also can lead to hyponatremia. So we need to be careful while anesthetizing these patients, or we need to optimize the potassium levels before we take them up for surgical procedure, because hypokalemia can interact with our neuromuscular blocking agents. Centrally acting antihypertensives like clonidine can lead to a refractory hypotension and severe bradycardia, which, if stopped before the surgery, can lead to a severe rebound hypertension. Beta blockers interact a lot with our inhalational anesthetic agents. It synergistically can suppress the myocardium and can lead to hypotension and bradycardia. Similarly, calcium channel blockers also will interact with inhalational anesthetic agents, leading to myocardial depression, and also it will interact with neuromuscular blocking agents. ACE inhibitors and ARBs lead to refractory hypotension in synergism with anesthetic agents. There are two schools of thought. One says we need to discontinue ACE inhibitor or ARB on day of surgery because it can lead to refractory hypotension. The other one says if your monitoring is adequate and if you're confident in managing the hypotension or hypertension during the surgical procedure, then ACE inhibitors and ARB can be continued on the day of surgery. Now, goals of anesthetic management. We need to have a detailed preoperative evaluation of the patient, which means that this patient will be worked up for ambulatory blood pressure monitoring, ECG, echocardiogram, and if need be, a dynamic echocardiogram, that is stress echocardiogram. Perioperative risk reduction has to be done. Pre-medication has to be given so that the anxiety component which will lead to increase in blood pressure is taken care of. A balanced anesthesia technique during the surgery, proper monitoring intra and post surgery of blood pressure has to be done, and parenteral medication for good pain-free anesthesia. Now, what are the main pathophysiological causes of perioperative hypertension? During surgical procedure, patients might have hypertension, and this is more so in patients who are already hypertensive. It is basically because of increased systemic vascular resistance, increased preload, rapid intravascular volume shifts, which can happen because of anesthetic agents, renin-angiotensin activation, and adrenergic stimulation, both cardiac as well as neural, stimulation, overproduction of serotogenic agents, and baroreceptor denervation because of anesthetic agents, altered cardiac reflexes, and depth of anesthesia if depth of anesthesia is inadequate. Perioperative risk reduction can be done by effective control of blood pressure, using good antihypertensive therapy, adequate hydration of the patient. Choice of anesthetic agent should be so that there is minimal interaction with the antihypertensive therapy these patients are on, and adequate analgesia and other factors which can lead to hypertension during in perioperative phase. The main etiology during surgical procedure or anesthetic intervention which can lead to intraoperative hypertension are during intubation, if there is inadequate anesthesia, depth of anesthesia, hypercapnia, hypoxemia, if adequate pharmacological adjuvants are not given during the surgery, pheochromocytoma, on certain surgical procedures, especially thyroid or adrenal surgeries, in spite of adequate depth of anesthesia, can lead to increased blood pressure during the surgery and bladder distension. And last but not the least, during extubation, also these patients can have hypertension. So this is all these factors have to be actually managed during intraoperative and also post-operatively. In post-operative, the first few, one thing I want to mention, most of the hypertensives who actually have cardiac insult in form of myocardial infarction or strain or cardiovascular insult, cerebrovascular insult, it will never happen during the surgery. It will happen only post-operatively within 6 hours to couple of days after the surgery. So post-operative management of hypertension is very essential component of managing these patients. And the main components which can lead to post-operative hypertension are inadequate oxygenation, tachycardia, or altered thrombotic potential, which can all lead to post-operative hypertension. So the commonest management modality is adequate pain relief and managing perioperative fluid shifts. To conclude, hypertension is one of the most important risk factors contributor for perioperative morbidity and mortality. Optimization is the key to safe anesthesia. Good monitoring and taking care of all the precipitating causes can deliver a safe and excellent surgical outcome. Thank you. Any questions?
Thank you for the interesting presentation, Dr. Popli. And I would like to thank you for your valuable contribution to today's webinar. And I'm sure the participants greatly benefited from your knowledge.
Thank you, Sana.
If anyone has any questions, they can unmute themselves. Before we conclude today's webinar, I would like to invite Dr. Sanjay Kumar Gupta to share a few words about their thoughts on today's session.
Well, it was my pleasure to be a part of your webinar on the occasion of World Hypertension Day, organized by the Medical Education Society of GAIMS Mauritius. I was really impressed with the presentations made by the students of SSR Medical College, and I wish you all the very best for your coming final year MBBS examination, and I expect all of you to excel in whatever field you choose in future. Thank you.
Thank you, sir. And I would also like to ask Dr. Gurpreet Singh Popli to give us your feedback on how you felt about the webinar and the topics discussed and the overall experience.
My overall experience has been really good. and it was a pleasure to be part of this webinar. I would again convey my appreciation to all the organizers and the speakers for such good discussion on hypertension in on World Hypertension Day. In fact, I appreciate the very fact that you guys took this initiative to organize this webinar, which is very informative and eye opener for almost not only medical students but other people also. A layman also would have learned a lot from this in this webinar. So congratulations to all of you, and my good luck to all of you for such endeavors. Good luck for your coming examinations also. Good luck.
Thank you so much,
Uh,
sir.
just a moment. I would also give my uh, best wishes to the Anna Medical students also, that I think they were also a part of presenting this webinar. I think they were also a part, so I also congratulate them and wish them all the best in their future. Thank you.
Thank you, sir. I would now like to invite Abhishek Kashyap, the president of GAIMS Mauritius, to speak on behalf of the team.
Hello everyone. I know it's quite late in India, so firstly I would like to thank the speakers, Dr. Gurpreet Popli sir and Dr. Sanjay Gupta sir, for taking out your time and taking this webinar at such a odd time. But in Mauritius, sir, that's time we could afford, and we are in mid of our exams. So really thankful for you for your time. As I'm Abhishek Kashyap, I'm a final year medical student at SSR Medical College and the national president of GAIMS Mauritius. And I would like to thank all the speakers and the students also from both the colleges, SSR Medical College and Anna Medical College. You have been absolutely remarkable, and thank you for sharing such insights. Your contributions have been really invaluable. And also to emphasize the importance of hypertension. Hypertension has been a silent killer that affects millions of people worldwide. And today, and on the World Hypertension Day, this webinar was an initiative by our organization, which looks forward to bring opportunities for medical students and help them upskilling them so that they can provide a better patient care. So this was our effort to give back to society as a medical practitioner or future medical doctors. So at our organization, we are a plethora of medical students, and GAIMS is an organization that works in India, Nepal, Russia, Uzbekistan, and now in Mauritius. So uh, this is the first webinar on a medical topic, and I'm really happy to see how the team worked hard for this, especially Ankit and his juniors, all juniors from both the colleges. So it's a very good initiative, and I'm very thankful to all the speakers. So thank you so much. And also, Ankit has shared a form link in the chat box where you can fill it up, and you will be given your certificates as soon as possible. Within, I think, within a week or so. So, but you need to fill up the form so that we can have the list of active participants who have been present in the meeting. Thank you.
Thank you so much, sir. And I would also like to request all of the attendees to switch on their video cameras so that we can take a snapshot of the participants and the attendees in today's webinar. Can everyone please switch on their video camera so that we can take a screenshot of all the attendees and the presenters? Thank you to all our presenters and the attendees today for attending this session.